faces from there and actually Henderson too. Well, I wanted to talk to you guys about what I really dabble with more is some of the pain and I guess addiction, and I thought that because that's always a fear of people that have opioid use disorders, alcohol use disorders. They go to the hospital, or they come to a clinic like ours for surgery, and most doctors that don't really understand opioid use disorder, they freak out, or they just they just throw their hands up. They run around what's going on. Even the hospitals do this, and it's just I can't tell you how many calls we get over this, and trying over the years to get this fixed so people can actually enjoy their lives. It actually all started, I hate to say it all started because it makes you're going to think I'm going to tell a long story, but it all started way back actually at Henderson when I came here in 2002. I guess it was a nurse that worked with me, well, she's passed now, Miss Dolores Edwards. Some of you guys probably know her. I remember, we'd have our pain clinic going, and we had lots of people coming in, and we eventually identified some that had opioid use disorder. And we ended up thinking, well, we got to help these people too, instead of just turning them to the streets. And I was like, wow, this is something we could do. So we got into that in 2000, I think around 2004 when it was new with some of the, the newer treatments. And she'd always said, especially I remember we had a pregnant lady, was living in the cars and things like that, and had the most horrific withdrawal symptoms. And I was like, well, we can try it, like this new drug, and see what happens. And I remember how well she got, and you look at her now, she's actually working in a hospital setting. I still know her, still a patient, and she's got sober for, 15 years now.
Wow.
And you wouldn't know it. And you would know that little kid that was living in that car has gotten to be a teenager, past that, and even gone on to college. So I was pretty amazed how she did that. But we went through like almost the whole life, a whole couple of pregnancies and a couple of deliveries. And I remember how people treat her, I don't want to use this word, but like crap, and how people just don't understand. So we dug into that more when I was in Henderson, and I started thinking, well, we can help a lot of people get through recovery and try to, get their lives back, especially the ones that really wanted it. And you can tell those that really want it because they have an inner drive after a while. They make lots of mistakes, but we don't kick you out. We try to get you through it, and we try to, you got to figure out what you did wrong or what drew you there. And it's the old adage, people, places, and things. That's really true. You got to change that. If you never change that, you're probably not going to do well. Or you got to be able to forecast, at least look around the corner and say, hey, I know if I go this way with these set of people, I'm going to probably end up doing it. Even if you really don't want to do it, it's no different than food. It's no different than candy. I want to go to the candy store, It's no different than putting it there and saying, hey, don't touch that. I guarantee you most of us couldn't do it if we really wanted it. And so that's the same thing with any substance abuse. If you put it there, you're around it, you're going to have those problems. All right? And that all goes back to the brain. And most people, if you take a nice picture of the brain, I wish I had some slides, but you got a big piece of the brain, everybody knows your big brain, and you got this front part here. That actually is very important. That's the executive, or we call the controller, of a lot of things like your thought processes, or if you see a person get a stroke, they lose that if they get a stroke in this area. And that's the part that makes you be nice, or whatever it is mean that you need to be, or drive you executively. So those wires from the reward center, which is deeper inside the middle part of your brain. I'm not trying to get too scientific because I know this is not medical, but you go in, those reward centers are there and have certain hormones and enzymes that are stimulated. All right, so they They're stimulated by various things. Nicotine, opiates. You know, some of us like our opiates too much because it does things. I always said to people, I can tell what type of drug you're going to abuse by how you respond to those drugs. Some of us like ups, some of us like downers, you know? So that's the type of person I can tell, you know, what you're gonna abuse, because there's certain classes of those drugs. And so when we target those receptors in the brain, we target those receptors as well. For if you're going down, we try to go up, you know, you try to do the opposite, see if that works. And so all of this started way back, I think in the 1800s, we had, you know, we found opium and we switched that to, you know, the morphine. That's one of your natural drugs, morphine. And it really took off, morphine, in the 1800s to, it's 1853 when they came out with the needle, the hypodermic needle, when they found that they can shoot that into circulation. That was a major breakthrough then. We actually used it for our soldiers in the Civil War. That was really good. And some people started liking that a little bit too much, and then the government comes in and obviously wants to figure out how they can make money on this. So they developed this law, something called the Harrison Act in the 1900s, and they make their things, money on that to try to say that, you know, legitimate use of those type of drugs could, you know, you could be sold or whatever. Then you develop again over the years, and in the 2000s, as you start moving to, you know, the 2000s, then you get, you know, almost like the DEA and the Control Acts and all those things come in, regulate things and who can do what and that. And as we get up further and further in the years, you know, let's say like in 1996 or so, you know, we had the little thing, and even in the hospital, I don't know if people remember if they're that old, we used to get slapped on our wrist if we didn't give you enough pain medication. You know, they would come by and say, well, this person said they was like 20 out of 10, and you didn't give them anything. You know, as a doctor, you're like, what? And then they were like, well, if you don't give them anything, you know, you're going to, you know, you can get disciplined or whatever, you know. But now the whole thing is swung the other way. But back then, that's the way it was. And then, of course, the prescriptions went up and up and up and up until like 2008 or 9 when our overdoses surpassed the motor vehicle accidents. And that's really what's creating all of this now. Years later, you know, the government's always a few steps behind. When they saw the data, but then I guess they try to figure out how to correct it, and that's how your CDC gets involved in 2016 when all this stuff. And then they reversed some of that, and, you know, with 2016, they obviously scared a lot of people too. If you wrote this much and that much, you know, you get scrutinized, and they look at the top. In our state, North Carolina, they looked at the top 10%. And, you know, they went after the top 10% of writers and did whatever they did with them, scared the Jesus out of them. And then now they're trying to go back the other way, soften it up, because there's been pushback, because unintentionally the pharmacists and, you know, even doctors, people just got cut off for everything. You know, even medications for addiction. You know, nobody wanted to write that, and it just scares people really badly. So when you look at addiction, you have to ask yourself, because everyone's always walking around, oh, this person's an addict, that person's an addict. You don't really even know they're addicts. You don't even know they just label people. And that's probably not a good idea. You know, they really need to know, understand like the definitions of those things. You know, you go through phases, you know, you could be tolerant of medication, which is, you know, when most people say, I'm used to it, or whatever. You take it enough, your body adapts, and you get used to that. And there's a difference between getting used to it versus somebody physically dependent on the medication. You know, if you stop the medication when you're dependent, you're going to go through, say you're on I don't know, everybody knows OxyContin. Say you're on that. You know, you stop that, you're going to go through withdrawal anyway. It's going to look like you're an addict in somebody's eyes, but that doesn't mean you're an addict. That's a normal physiological response to that cessation of medication. No different if you stop the blood pressure pill. No different than you stop the diabetic pill. But you can't get people to understand that. You know, especially some doctors don't understand it either because they feel like that's, I don't know if you've ever been to a doctor, but some of them have one or two ways to look at it. You know, if you're in that situation, let's say you're withdrawn or whatever, that's really your fault because you can control that. It's a mind thing. And then there's another school that thinks, well, this is a chronic illness, a disease that you have to treat. So people look at addiction that way. So some doctors, we look at it more as a chronic illness and disease. It's no different than me than diabetes, blood pressure, or, things like that. But there are a lot of other people that look at it the other way around and say, well, that's your problem. You have to suck it up and deal with it. And then, it'll go away. It doesn't always work. It doesn't work. You have to come to places like this for it to work. So when they learn those definitions of the tolerance I was mentioning, which is the first one, you get used to it. The dependence is when you have your body adapts to, but you tend to go into withdrawals and stuff just because if you were to naturally stop that medication. Doesn't mean you're used to the medication, but if you stop it, that's what you would see. Now, somebody that has opioid use disorder is a little different. We have, you can get into the same thing, but the problem with them is they tend to crave the medication more, or they're doing more harmful things to themselves or somebody else. Disrupting relationships, disrupting their work cycles, lying, cheating, getting in trouble with the law, missing work. Things that's very important, whereas these other folks don't do that. So when you look at the biggest thing you can say, somebody would say with opioid use or even alcohol use or any use disorder, even meth, you have to say this is a compulsive activity. If it is, if you have any of that compulsion in you, that's going to tie you right to that pretty quickly. If you're looking for it, you're not going to come out there and say I'm compulsive. It's the things that they do and say that leads you to whether this person is compulsive or not. All right, so that's how that works. It's all on a spectrum. If you ever heard of that word, spectrum, where you start out maybe with some risky behavior, and you make your way down that to the path of opioid use disorder, or you don't make your way there. Some people trip up early and get out and stop. Some people keep going, and that's not everybody. I can give everybody in this room some pain pills. Probably 10% of these people come out of here. They're the ones, if they're going to be addicted to it, they will be. But the rest won't. So unless I'm giving it to somebody that has the problem before, I'm pretty sure you're going to go that way. And the way that we try to screen people is looking at various things. We look at age. If you're not too old, it's a risk. If you got certain things in your history like alcohol or family history, whether it's yours or somebody else's personal, we have to pay attention to those things. Or any kind of drug abuse, we really pay attention to that. And sometimes which separates the men from the female, in the female we do pay attention to any women that have been abused when they were younger, because that puts them in that category as well. For some reason, that makes them become more, risky for opioid use disorder. And of course, we look at the mental aspect. If you have any serious mental things like major depression is one, or schizophrenia, or bipolar disease, or whatever you have, schizophrenia, we have to really strongly consider that. And also, if you keep smoke is not a big thing, but I always take that into consideration. If you smoke a lot, because it's like an addiction too. And so there's a tendency for that to happen. So when we see you like in a hospital setting, or getting ready to go to a setting like an acute pain situation, I feel like we should treat the person the same as we would anyone else. I don't really see that any different, even if you're on something. we still have to, give you everything I feel like you deserve, what everybody else gets, and it doesn't mean more, it doesn't mean less. It just means the proper management. And that is difficult for a lot of folks that are not used to, I call it a vicious cycle of pain and addiction. So it's a bit like a wheel. You go around and around and around, and it's easy to get into either one of those if you're not careful with your thought patterns. So what we tend to do in somebody like that, we offer them lots of different options. In particular, like a hospital setting, we have more to do there, and we can control you more. But outpatient-wise, say in our clinics, like the orthopedic clinic, we would help them manage somebody that was going to come in for that, and we would recommend. Let's say you're on, I don't know anything. Let's say methadone. Say you're on Suboxone. Say you're on nothing. We have to break it down like that. And then, obviously, if you're on nothing, we would look into your history more. And then, you still would get managed pretty much close to the same, but now that they have the STOP Act, you can only get so many days of treatment, right away. It'd be like 5 days initially, and then 7 days after that. But that doesn't apply to a chronic person necessarily, but it's an acute person that's like needing, like say you broke your leg or something. That's how that works. And that still spooks people. So, but the way we would manage that, we would just, give them whatever we kind of know what some people, we have some data what people get over time for certain injuries, say you broke your leg, and how long you should recover. So we look for that same recovery pattern. You should recover it on an average time. But of course, there's always some outliers and people that just not going to recover at that time. So we take that in consideration too. But for someone that has opioid use, we're not going to go on and on and on and on. In fact, I try to get people off of that as soon as possible. And most honest people that's really trying to be sober, they don't really want to be on it anyway. I mean, not even after day two, they're ready to get off and move on to something else. They're not really interested in that. So I don't really have a battle with most of those people. And the battle you have with somebody that is not really ready, and not everybody's going to be ready. And we try to catch them at the time they're ready. That's the only time we can do it. And if we all work together on that, is even they come. Some people have sponsors, and they some people actually bring their sponsors with them, so they can chit chat with them so they can learn how to what they need to do. And we just try to transition them off of whatever they're on in a reasonable amount of time. And sometimes quicker than we would somebody that isn't on it. And of course, we monitor all of that with testings, and we check levels, and we see people do weird things with those tests sometimes. Like bring urine or... I don't understand why they would do that when they know they're going to get checked. But people do that and they don't think you're going to see it. But, we know the metabolites. And, you might fake the cup out or whatever, but you're not going to be able to fake that scientist out. It's just we have so much we can pull out of that urine. And we can pretty much pull anything out of it if we find the right lab. So we try to incorporate all of that into what we do. And then we get the person, in the right mind fit for a surgery or post-surgery event, and then just carry them through. And they kind of do pretty good with that, in my opinion. And most of them I don't have any problem with, to be honest. It's sometimes the people that are dependent or opioid use person that don't really realize they are opioid use. And that's when the surgeons throw up their arms or whatever, hands, and say they don't want to deal with it, and they kind of feel like sometimes some of the surgeons probably, don't really want to deal with that because they just want to do surgery, and then move forward. But a lot of times they have to deal with it sometimes, but they don't want to. I wouldn't either. I guess if I was a surgeon, I guess I don't know. But since I'm, in this area, I kind of deal with it all the time, so it's kind of like second nature for me. But it's not for them, and they seem to be pretty out of order. So we try to give them all kinds of other medications too, because I try to use like what we call a multimodal approach, where we kind of use very low levels of almost a lot of different things. It seems kind of weird to use a bunch of stuff, but that's what we do. We use lots of little things so that you don't use a whole lot of medication on one end to create toxicities, messing with people's kidneys or livers. And actually that kind of works because you're targeting maybe, 5 or 6 different receptors that a person may have versus saturating one receptor. So that's kind of how it's going nowadays. Rather than just going up and up and up and up and up, that's really not the way to go anymore. Because a lot of people start going too high, it leads to problems, like, overdose, respiratory problems particularly, and just falling out somewhere. So, actually with something like Suboxone, you can kind of go up more on that, because that's, even if you go up on that, it really tails off. It's not going to get any stronger. It's not going to raise your levels either. It's just going to come like a little flat curve. And you go like that, but an opiate would just go straight to the roof. It would just, it wouldn't be long before you're gone. Especially if someone is not there, you're pretty much done. But nowadays, we're seeing a lot we're seeing a lot of the fentanyl coming into play, and a lot of that's, I don't know where it's coming from, but it's a carfentanil type, and it's very strong. You're talking almost 10,000 times more lethal than a prescription that we could give you, and that's just a small amount. So it doesn't take much. And now things are being laced with that. Even marijuana has it. I've seen a couple. We had a couple here in our county, Granville County, that had that in there too. And you smoke marijuana, you don't think you're going to be getting that. But at least I don't know most marijuana people that want to get on fentanyl. But the two that I saw, they didn't do too good at first, but they made it. But then we got a lot of people that use heroin, and they don't make it too much because they take too much of that. Plus, that is not a good thing. That's just going to shorten their breath, or they're by themselves when they're doing it. We try to take risk management with some of these people. They really, if they're going to do that, they need to be with somebody, so they at least can do like Narcan or something to bring them back. And that's kind of been the thing now too, I'm seeing. So to the point where some people are just doing that to do that, which is, I don't know, it's like playing Russian roulette for some people, but that's what they did. But they're still here. And the thing is, we got people that shoot needles in their necks, break needles off, needle could go in the brain, but for some reason it didn't go that way because God didn't want it for them. But they're still here. And a lot of them still do other things, but they don't do, too many legal drugs anymore. Some people switch, obviously, to, say, alcohol. And then some people have switched in this community to meth as well. It's very cheap. But the fentanyl is really taken off a lot everywhere. I remember when I used to drug test, I never used to see any fentanyl, even with the heroin. Never. It wasn't until 5 years ago we started seeing a lot of that. Just like everybody has every batch. It seems like it's in there, and people don't even know it. It's just, and I don't see how they would. I guess they couldn't know because the person that gave it to them doesn't know either, probably. And it's not like it's got a label on it. It's got this, and this. It's not FDA approved, so it's been tough for people. But for the people that have made it, it's been a really miracle. We have some great people I wouldn't thought would have made it, but then they made it. It took years and years and years and years and years of. Sometimes it takes a couple of years to get someone straight. Sometimes it takes 3 years. Sometimes it takes only 3 times. It depends on what makes them straight. But I would say most people, if they hang in there about a year or two, they're going to be okay. And then it takes your mind. Centers in the brain where the wires go from the middle part of your brain to the front. it takes a while for those to become, well balanced again, because it's used to being bombarded with other things. And so I think, it's getting better in that way. But if you get better and you feel like you can move on and you get in a nice group and have good support like you have here, it sounds like, you'll always be good for a while. Not to say you won't think of it, but you have strategies to avoid getting yourself in the wrong direction. And that's really, really important. From understanding, you guys help support people here, and that's I've been told that by Rosemary, actually, here, who's somebody I know, and she told me that they have great support here, and I really like that. So that's one of the reasons why I came down here, because she asked me about it, and I said I would do that. And I thought it would be good to see people that are trying to get better, are doing better, and hopefully will stay better. And I did tell her I would also give her a donation. So I'm going to do that tonight, too. Give you guys a donation to help out for that. And keep you, hopefully you can sponsor somebody and get somebody to where they got to go. Because in my heart, I really believe that's a good thing. And I've seen a lot of people in my life that really would have been forgotten from Henderson or Oxford, and they're doing great. And they're not forgotten, at least by me. And I've got some patients that have been with me, 20 years. And I've seen them come, like I said, from the bottom, struggle. Never thought they would get better. People always ask, aren't you going to give up on them? Kick them to the curb? Nah, as long as they keep coming and getting right, eventually they do. If they don't get right, you know where it's going to be. They're going to be somewhere boxed somewhere. But if you give up on them, you have no choice. In that way. So that's how I look at it, like that way, because no one's going to help them. No, most doctors won't help you. I mean, they'll help you when you're coming up. Everybody loves the A student. I mean, I can teach an A student. I can teach an honorable student. The question is, can you teach somebody that's really struggling? Or are you willing to hang in there with that person? And that's it. And I know in medical school, they don't teach us all that. I remember saying that with a lot of people I knew, close friends. I didn't even know half the stuff about alcoholism. Like, you see a lot of people doing drugs and alcohol, but I never understood that until I got later in my life. Because they don't really teach you that in school. They don't teach you how to take care of a person that's dependent or has a use disorder. They don't. And I wish they did, because that would be a lot. But it's not happening right at the rate it should, but it may be getting better now, because they're trying to put some money into different programs and maybe get people going in the right direction. So I'm kind of feel passionate about that, and I think people will do better as long as they can stay focused, stay away from, those three things: people, places, and things, and keep your life happy with God. Amen. All right? So I think that's all I have to say. Thank you. Thank you for having me. That was very educational. Amen. Amen. Thank you for coming out tonight. That's a blessing. I think all of us need to give more part of our life to help others in addiction. And I know we do a good job of that here tonight. People, y'all love the community. Y'all love to help other people. And y'all love to use y'all experiences to help somebody else. That's what it's all about. And we can't do it by ourselves, right? It takes everybody in here to go out and spread the word. It takes people like Dr. Smith over there to go spread the word, to come help us, to be a part, to give us a resource and a tool that we can pass to somebody else. And I thank God for that here tonight, and I hope y'all enjoyed that. We're going to close this up with an altar call. Anybody who didn't get a chance to come up to the front, you'll have that chance. If you need prayer, I'll be standing to the side. And if you get a chance, just thank him for coming tonight and say, hey, we appreciate it tonight. I know I did, because we can never learn enough about addiction, right? And at least we got something tonight that we can take home and knowledge that we can share with somebody else. So praise God for that.
All right.